had knew there were publications before and looking at the papillary muscle, which is typically difficult to identify. And in regular late enhancement images, if you want to look for scars. Now, in this, there have been previous reports that if used, for example, short inversion times, that you can improve the visibility of these infarcts or small scars. And this is what this paper addresses, but in the context of mitral valve prolapse. We know that mitral valve prolapse poses a significant stress on the left ventricular myocardium, especially on the base of the papillary muscles. And there has been speculation, okay, this increased stress of the base, but also of the papillary muscle itself may lead to injury. And this injury may be then visible on late gadolinium enhancement. Just on late standard LGE images, it's not that easy. So what this group did is they looked at 60 patients with known mitral valve prolapse who were referred for clinical scan. And then they used standard imaging, including late gadolinium enhancement and a technique called dark blood late gadolinium enhancement in comparison with the standard. So if we look through the methods, otherwise was a 1.5 Tesla system, standard dose, or actually a slightly higher dose than what we are using actually, of 0.2 millimoles per kilograms gadobutrol. The images were analyzed using standard methods, and looking at the fibrosis, these two techniques were used, bright and dark blood LGE, and this is maybe the most important visual of this study. Here, how identified here in the cine images, there's this part of the papillary muscle, which sometimes can be multi-headed. And we also in our group have the feeling that the structure of the papillary muscle apparatus is somewhat linked to the overall structure of the left ventricle, sometimes associated with a little bit more of trabecular tissue or relatively increased trabeculation. And then you see in the standard LGE images, this is what you could easily overlook. But in the dark blood, you see that there is a small spot, a bright spot, indicating late enhancement related to the papillary muscle. Again, that is related to the mitral valve prolapse. So this is a typical case of those. So the study population, it was carefully assessed for the ruling out any other reasons for scars in the papillary muscle. You see some more examples. So you see it can be a pretty consistent finding. And we even had just a case in our institution here at McGill, very, very similar. It was just more in the trabecular tissue, so not directly related to the papillary muscle. So what they overall found is that, of course, pretty obvious that looking at the sensitivity of the technique to identify papillary muscle scars, that there's a higher sensitivity, and then they also looked at the differences between those patients who had this LGE in the papillary muscle and those who didn't, and there was actually no big difference. So all in all, the takeaway of this paper is that dark blood late gadolinium enhancement improves the detection of papillary muscle scars in patients with mitral valve prolapse. And of course, this needs to be confirmed in larger samples. But the takeaway here is, if you have a patient with mitral valve prolapse, it may make a lot of sense to look at the integrity of the papillary muscle and using dark blood images for that. So Now, the next paper we will discuss is from, and let me just share my screen again, is from Angélica Romero Daza from Madrid. It's the group around Borja Ibanez and Javier Sanz and Valentin Fuster. They do a lot of great experimental and clinical studies. And they also look at mitral valve prolapse, but a slightly different focus. They do not look for the scar or for injury, but what they look at is what is the overall appearance of the structure and the apparatus of the mitral valve apparatus and the left ventricle in patients with mitral valve prolapse. So what they do is they looked in standard sequences for all the features you could look at, the function, volumes, and different anatomical descriptive parameters. So what they found is that significant mitral valve regurgitation was in about 56 patients out of the 80 that were studied in total. And they found that patients with mitral valve prolapse had an enlarged left ventricle, had basal inferolateral hypertrophy, which of course could be related to the increased mechanical challenge that this part of the myocardium has, because that's the base of the inferolateral papillary muscle.
Sorry, Matthias, are you sharing your screen, because we cannot see anything?
I'm sorry. Here you go. I just clicked, did not click the right button. Thank you. Here we're if we briefly go through that again, so 158 patients were finally analyzed out of the 80, and so what they looked at here are several markers. So this is outlining some of that. So the basal wall thickness, that is the basal hypertrophy. That's what they looked at. They looked at the papillary muscle, the length of the visible cords. They looked at different angles and basically looked in detail, how does the morphology and the structure of the left ventricle differ in patients with mitral valve prolapse from those without. So the patient's characteristics are not necessarily that important in that context. So here they looked at the differences between volumes and such. So what I already mentioned, the left ventricular volume was slightly higher in patients with mitral valve prolapse, the end-systolic volume as well. And these are indexed values. So this is always important when you have trials, that you look at index and not just absolute values. And of course, the end-diastolic diameters were also much different. But then the other important aspect is here, the basal to mid-inferolateral end-diastolic wall thickness. So especially the ratio between the basal to mid, that was different with some overlap, but still statistically significant. And especially was most of the differences between controls and patients with mitral valve prolapse are more pronounced in those with mitral valve regurgitation. So those are, from my point of view, were the most important findings. So here in this paper, they go through a large list of all these descriptive quantitative markers. So the distance between the papillary muscle to the anterior annulus. So it's quite extensive, and there are a couple of nice features, and will not take the time today to go in very much detail. I wanted to point out one additional interesting aspect, and that is a strain. So we know that strain can be used to describe regional abnormalities of left ventricular function. So the deformation of the ventricle, which is typically more informative than just ejection fraction or stroke volume. Ejection fraction is probably the worst, but even stroke volume or stroke volume index do not necessarily reflect any regional abnormalities. And while there are still some methodological, let's say, needs with respect to standardization of these measurements, differences between softwares, etc., strain imaging more and more seems to be helpful in better understanding of disease. And this may be a good example here. So here you can see in the table, and then also as a figure, the peak systolic, longitudinal, and circumferential strain values in controls, and then in patients with mitral valve prolapse. And you see there are quite a lot of statistically significant differences with for the basal anterior, mainly the basal parts of the left ventricle. And you can also see that that in blue here, the abnormal regions. So that's the HA segments number 1, 2, and 6. So the anterior basal wall, including the lateral, are significantly affected. So here you see a patient with mitral valve prolapse, and in two different views, the short axis view and the 4-chamber long axis view. And here you see the control, where you have a homogeneous distribution of the strain values, and here in the bullseye view, you can clearly see that it's basically happening in the base. So the other interesting aspect I found in this paper was that the angulation of the fibers may have a significant role both in the pathogenesis, in the course of the disease, but also of course in looking at from a diagnostic angle. So this is interesting to read, that the angulation of course has significant implications on the mechanics, and that some of the abnormalities that we see and that have been described in that long table here can be explained by the angulation. And so that mitral valve prolapse should not be just seen as a disease with just a thicker mitral valve and basically floppy leaflets, but also as a problem of the geometric setup of the left ventricle in a three-dimensional space. That also refers to the motion of the entire plane. And what I do actually in clinical routine in the 4-chamber view, and I don't know, I think I saw that here in one of the first two in the systolic, yeah. In the 4-chamber view, in mitral valve prolapse, you typically have a very fast displacement of the valve. That's the base is at the right place, but then you have the prolapse, which is actually moving towards the atrial side of the plane. Of course, that's what we typically see as mitral valve prolapse, but that is sometimes it sometimes may appear that some parts of the leaflets do that and others don't. And there is definitely an entity which I would call a partial mitral valve prolapse, whereas the typical prolapse would then affect both. So the when you talk about the motion of the plane, what they're doing here, then you of course have to really know what you're actually talking about. So the let's say the base of the leaflet, of course, stays at the place it cannot kind of move, but the visual appearance looks like there would be a disjunction, so that the whole mitral annulus would move in a kind of an opposite direction than it usually does. So these are some interesting aspects here, which deserve attention. And certainly this is just, this is not an easy paper to grasp in all its detail, but from my point of view, the take-home messages are described mainly here in their abstract. Take-home message is that mitral valve prolapse has a large number of features with respect to the morphology, the structure, and the function that go far beyond just the valve itself, but include the architecture of the left ventricle, angulation of the papillary muscle apparatus, regional hypertrophy, especially in the anterior and anterolateral and anteroseptal basal segments that can serve as a diagnostic marker, but also with significant consequences on the function by strain, but also in the long term function that may affect the architecture of the left ventricular secondary to these initial issues. And then of course mitral valve prolapse, which typically in the 55th and 6th decade of patients may then lead to mitral valve regurgitation and downstream effects on left atrial size and left ventricular size, and in a certain proportion of patients leading up to heart failure. So that's why it is important to find new diagnostic markers that may predict the course of the disease earlier, because with mitral valve regurgitation, we know it's the challenge is that you may miss the point of no return, and it may then be too late to operate on mitral valve regurgitation. And CMR in general has made huge progress over the last years and is now more widely accepted as the actual standard for assessing the severity of mitral valve regurgitation, although echo is of course much easier and easier to get, at least. I don't think it's easy to assess it with echo because of various reasons. But beyond the role of CMR in mitral valve regurgitation in general, I think this paper highlights the potential of MR to also offer additional markers that could serve fairly early during the disease. The referring physicians may want to know where this is going, whether they have to keep an eye on this patient or not. And these markers may actually help in guiding decisions that refer to, okay, what's the follow-up interval for these patients? How early do I have to think about a repair or surgery, whatever I want to do? Mitral valve interventions are also getting more and more used, and there may be some role for transcatheter or arterial implantations of valves in the cath lab. So MR is better set up than any other imaging modality to identify such markers, and I think this paper did a great job in outlining some of that, and hopefully it triggers more research on the prognostic value of these findings. And I'm sure this group does that, but I also hope that others will join in. So with that, I want to give everybody a chance to chime in. And oh, Angélica, I didn't see you coming in. So maybe you can, from your point of view, I didn't see you earlier. I should have jumped in, I'm sorry. So I hope I did your paper justice, and maybe you want to comment on how you what you personally learned from that study. Thanks for joining.
Thank you very much. I think you have made an excellent summary of the paper. I'm sorry for the inconvenience. I had some issues to connect, and I'll try to do it on time, but the link didn't work, whatever. I'm sorry. I think you just made excellent points about the MVP, which is a pathology that we tend to think recognition. It's just, you can see those patients, the morphology, even if you don't, you cannot sometimes make some like evident difference with normal patients. Like you know when you see them that the pattern, and then the ventricle is also different. Even like the part that it makes a difference in our paper is that we also did these comparisons with patients without significant MR, and even those patients with what we call borderline MVP, those patients also have like certain characteristics of the ventricle that you can like infer that in the future maybe they're gonna have like a more evident disease. And I think I'm a big defender of the MRI. I do like advanced cardiac imaging, and I love the echo also. But I think this pathology, maybe not the MR quantification, but the anatomy of the ventricle and also the anatomy of the mitral valve, the mitral annulus disjunction, and those characteristics are better qualified with the MRI. And I think these patients, even in the absence of a significant MR, we should consider the MRI, because we also saw that these patients have with very frequently LGE in this inferior wall and intramyocardial, especially patients with, if we are suspecting some kind of arrhythmias or ventricular arrhythmias, this could be useful characteristics of the MRI. But I think in summary, we should think about, in this pathology, we should think about like a complex unit between the mitral valve and the ventricle, and not just the valve. That's our, like I think if we could put it like in a phrase, it should be like MVP is just not the valve, it's also the ventricle, which probably is included in this complex unit.
Okay, thank you very much. Any other questions from, if you can always use the chat box to put in questions.
I have a question, Dr. Patricia. Sorry.
Yeah.
Just about the first article that you presented. Did the authors find any prognostic value of the papillary muscle enhancement in terms of sudden cardiac death or ventricular tachycardia in patients with the MVP?
No, this paper by Amedeo Chiribiri's group did not look at prognosis. I think that's an interesting question, because if you have scarring in the papillary muscle, one could imagine that this may indicate a higher than usual or higher than tolerable stress, which in turn could lead to an overall different course with deterioration of papillary muscle function and then subsequent mitral valve regurgitation. But this was not addressed in that study and could not have seen. I'm not aware. Well, I have not spoken with their team about that. I'm not aware whether they are doing follow-up scans in these patients or not. Would of course make a lot of sense. That's a good point. Okay, and Angélica, were there any? Because mitral valve prolapse can be found also in different clinical phenotypes. Yes, we have these, let's say, like Marfan, or but also the other features of people who are at higher risk of mitral valve prolapse. So did you incorporate any of that, or are you looking at any of that? Because that may be part of the picture.
Well, for now, we are continuing to work, especially with the tissue characterization in the MRI, not just the LG quantification, but the T1 mapping. I think that's, well, right now the T1 mapping has a field in almost everything, right? And we are interested in the tissue characterization and also the relation with the ventricular arrhythmias. That's our next hypothesis.
Yeah. Okay. Yeah, I have one final question before I hand over then to Bettina to announce the next one. What I'm very interested in is if you have a special stress on a certain on certain tissue, such as with mitral valve prolapse on the papillary muscle and so forth. And as you have seen that the wall thickness in these areas may, or the hypertrophy of the intralateral wall may give some clues here. What I always suspect is that this stress leads to some reversible repetitive injury. So if this patient, for example, maximizes physical exercise, goes for a half marathon or whatever, I could imagine that this stress poses enough injury that you develop edema, which then over time, if you have repetitive edema, this can even lead to fibrosis. So are you also looking at T2 mapping or T2 weighted imaging in these patients?
Well, that's really interesting. I think more like we study more like a general, if we're gonna give some patient gadolinium, we also look at the T2 or like in I say like part of our protocol is to include the T2 mapping, but just to see what happens. But we haven't thought about like being consistent in quantifying in MVP patients. But that's really interesting. Yes, that could be really interesting.
Yeah. So because that I would strongly, if you have the time and you have a good functioning T2 map, because the T1 may be increased because of edema, and so and we are learning that some diseases may come along with repetitive episodes of microedema edema with an increased T2. And we have seen that also in hypertrophic cardiomyopathy around the RV insertion points. These are always also more stressed than others. So that would be, I think, very interesting to look at. Okay, we're already at the end of our time. Thank you so much, Angélica, and for being around, although a little bit too late. So I jumped in, and I hope I did your paper justice, and then you probably would have presented it different. And we of course always want to have the authors around, but just this time in the interest of everybody's time, I had to jump in here. But thank you very much for coming. Okay, so I think I should hand over now to Bettina, who will announce the next weekend. I see that Caroline, you also joined now. I didn't see you earlier, so I'm sorry. So that's why I had presented the paper. But maybe I give you a chance just for a minute to also comment from your point of view what your main learnings were from your paper and your studies.
Yes, hello. Yes, sorry that we're late, but apparently there was a problem with the link, so we got the right link pretty late. So I'll try to share my screen.
Yeah, I already went through your paper. Just maybe that we already presented and discussed some of that.
Okay. Yes, I was totally unaware. We just got like 5 minutes ago the right link, so I'm so sorry.
Yeah, no, it's not don't feel bad about it. So I thought it was a very interesting and a very good paper. So there was one question which you may answer. What about the prognostic value of small infarcts in papillary muscle area? So could this predict bad outcomes, and are you looking at that? Because this is of course important.
Yes, that's actually a main point. So there was like a paper of 10-15 years ago which found a link actually between papillary muscle LGE and arrhythmias, but it is often cited, but this was only like in 16 patients, where 11 out of 16 had arrhythmias in LGE, and 5 had no LGE and no arrhythmias. And if you would just like put one patient in the other category, that would like change your significant value actually. So that's at present actually the only sort of proof but it has never been shown again in the last 10-15 years. Although that in autopsy studies, that was work by Cristina Basso, that they found that patients who really experienced sudden death, that they found fibrosis in the papillary muscles. But actually, to date, there are no studies really providing proof. So there is an outcome of LGE in the myocardium, because in 1/3 or 1/4 of patients, we see LGE in the inferolateral basal wall. That's what we also saw in our paper. And that has been shown that it is, it has prognostic value. But to prove that, you really need hundreds of patients. And so this still has to be proved. But I think the importance of this paper is that it depends on which technique you actually use. And it's really, I think, difficult because a lot of research is dedicated to what are bad prognostic signs on imaging in these patients with mitral valve prolapse. But difficulty is that actually a lot of these patients have either LGE, so about 1/3 in the myocardium, but also 1/3 in the papillary muscles. And these patients are not necessarily the same. We actually did find no link between the two. So this suggests that there might be different forces depending on the morphology of your mitral valve. But also, I mean, mitral annular disjunction has been suggested. And actually, it's difficult to find patients who do not have one of these things. And well, the risk on sudden cardiac death is not that high actually in this population. So it will need a lot of patients.
I think you make excellent points, and I think that's you're totally right. I also think we are really at the very beginning of understanding what to look for and what to be concerned about. So, and then your paper hopefully triggers then more research, maybe hopefully also from your end, to clarify some of that. And of course, hard outcomes, then you need large samples, but the quantitative nature of MR may allow for using some of the quantitative markers such as end-systolic volume index, which are quite sensitive to changes of the overall status of the patient. So it could be that these quantitative markers over time in longitudinal studies would allow to have statistical power enough to make a point, even with a reasonable sample size. So
yes, it's a very interesting field, and I think with this paper we hope that also a lot of other centers will implement this technique as the method we use, because there are several dark blood LG methods, and I don't know if this was discussed, but the method we use, actually every lab can use it. It's just like nulling the blood pool instead of the myocardium and looking at the PSIR reconstruction. So everyone can just like apply it. So we hope that a lot of labs will explore this technique, not only in papillary muscles, but also for subendocardial infarctions. So
no, that's also another point. And then unfortunately we'll have to finish that we are actually using, or have been using, the Scout, the TI Scout, because then this lesion is initially dark and then it turns brighter. So it is when you go through the different inversion times. So, but this is a very elegant one to just null to something else than to the myocardium, so that you detect and basically surface those small lesions that are otherwise drowned in the big sea of blood. Yeah. So thank you very much, Caroline, for joining, and all the best for your work. So
yes, thank you very much.
Now hand over to Bettina Bessler to conclude and to also announce the next one. Bettina.
Yeah, thank you very much for the presentations and the nice papers. Was quite surprised by this nice figure illustrating the pathophysiological circumstances of MVP. This was really interesting. So next CMR Journal Club will be in 2 weeks on March 2nd. And we will talk about devices in general. So we have a paper by the Lugano-Lausanne group from Switzerland, presented by Anna Julia Pavon, which demonstrates the feasibility of stress CMR in patients with pacemakers and defibrillators. We might have a second one. I'm still waiting for the final confirmation of the speaker, which will be on the supportive evidence of lead pacemaker MR conditional labeling, which is a related topic. So we always try to find related topics. So 2 device topics, hopefully next CMR Journal Club. And hope to see you all there. Stay safe and healthy.
Yeah. Thanks everybody for joining, and have a good day. And yeah, stay safe.